pleasure to stand before you all to present a topic on Etiopathogenesis of Parinamashoola and role of endoscopic study in its diagnosis. Let me start with a brief introduction. Among the symptoms, pain is universally identified as a signal of a disease. It is the most common symptom that brings a patient to a physician. Parinamashoola is one of the commonly occurring clinical conditions in medical as well as surgical practice. Incidence of Parinamashoola showing increasing tendency because of food habits and stress-related lifestyle. The cardinal feature of Parinamashoola is the pain during the digestion of food, which torments the person at every meal time, and it is the source of constant discomfort. At the same time, the features or the symptoms of Parinamashoola are vary according to the doshic dominance, are correlating both ulcerative and non-ulcerative asymptomatic disorders. Since this is an abhyantara vyadhi where it is limited to the scope of darshana pariksha or mimicking other diseases of GI tract also. Hence, whether the latest advances in GI system could help us for the easy and precise diagnosis. The study of Parinamashoola in light of endoscopic evaluation is one such method to arrive at a precise diagnosis that helps the clinician for precise treatment. And with some of the aims and objective, I conducted my study. It is an observational clinical study, and aims are the conceptual study of Parinamashoola in relation to dosha, etc. and clinical observational study of Parinamashoola and analysis of endoscopic findings and different types of Parinamashoola. And some of the patients I included. The inclusion criteria are the patients with the cardinal features of Parinamashoola, and I selected the patients irrespective of sex. And some of the conditions I excluded, like patients who are below the age of 15 years and above the age of 60 years, and patients with systemic disorders like myocardial infarction, HIV and hepatitis and tuberculosis also. And these are the observations and results of my study. Because of lack of time, I am not going to discuss all these things, and I will directly move on to the endoscopic findings in my study. In my study, I got the endoscopic findings revealed chronic atrophic gastritis in 40% of the patients, and 50% of the patients had duodenal ulcer, and 10% had chronic superficial gastritis, reflexive esophagitis and erosive gastritis, and 5% showed chronic atrophic gastritis with hyperplasia and gastric ulcer. And after this endoscopic finding, I tried to correlate my clinical diagnosis with endoscopic finding. For example, my clinical diagnosis is Vataja Parinamashoola and the endoscopic finding was erosive gastritis. And my clinical diagnosis in one of the 8 patients is Sannipathaja Parinamashoola, and the endoscopic finding is chronic atrophic gastritis. Coming to the part of discussion, the onslaught of fast food and cola coupled with the fast-paced stressful lifestyle. Parinamashoola is one such a disorder was selected for my study. Many scholars have correlated it mostly with the duodenal ulcer, but the present study there is no prefixed concept is there, and the patient symptomatology alone was considered, and later on an endoscopic evaluation was done. The gastritis, duodenal ulcer were the findings on the endoscopy. The nidana for the Parinamashoola are not mentioned in any of the texts, but the Samanya Shoola Nidana applies in case of Parinamashoola too, because it depends upon the Samanya Nidana as well as Vishesha Nidana. And as Parinamashoola is a Tridoshaja Vyadhi, we can consider the Tridoshaja Shoola Lakshana also as the positive factors for the Parinamashoola. And this Vyadhi is related to Annavasrotas, and because of Agni Dushti is the prime cause for this disease. That's why Agni Dushti Karanas and the Annavasroto Dushti Karanas are also be considered as the Nidanas for Parinamashoola. And the Anupashaya which were told in the classics are also considered as the Nidana are causative factors for the Parinamashoola. And incidence of Nidana in my study, all the three types of Nidanas like Aharaja, Viharaja, Manasika were observed in the patients. Among the rasa, Katu, Amla, Madhura rasa was elicited and Mausa Ahara was predominantly seen in my study. And Vishamasana, Viruddhasana, Pranitasana, Samashana and Natyasana were the common in all the patients, along with in some of the patients, Manasikarana are also elicited. Even in modern parlance, a clear etiology is absent for chronic gastritis. The causative factors for acute gastritis holds good here also. Other causes include reflex of duodenal contents, associated disease of stomach and duodenum. H. pylori infection is implicated with the causation of peptic ulcers and chronic gastritis. Other events with H. pylori to promote peptic ulceration include dietary factors, genetic factors and some of the psychological factors, etc. As per the text, the dosha may follow an avarana or a sannipathogen pattern of visheshan in the pathogenesis of Parinamashoola. Among the three dosha, the Samanavata, Pachaka Pitta and Kledaka Kapha are the prime doshas, and the dosha take their ashray in the Ado Amashaya and also vitiate the Rasa Dhatu as well as Pitta Jara Kala. They present the Pratyatma Lakshana of Jiryamana Kala Shula. The occurrence of Shula in this avastha is due to the Udirana of the Pitta, and the Shula is relieved immediately after consumption of food and after vomiting and on the completion of digestion of food. No Pura Rupa has been elicited in the class 6, but you can take some of the Vidagdas in the Lakshana as Pura Rupa of Parinamashoola. The Shula Lakshana may be attributed to the Karmatmaka Rudya of Vata and the Chalatva of Vata, that is obscured due to the Avarna by Pitta and Kapha. Shula may also occur due to the occlusion of Saumya Asrotas by the dosha. In the Uttarottara Avastha, the Rakta and Mausa Dhatu may also be involved. In the Upadrava Avastha, let me conclude. The clinical features of Parinamashoola are similar to diseases like ulcerative and non-ulcerative peptic disorders. Endoscopy plays a significant role as it is highly suggestive in different GI disorders which come in the purview of Parinamashoola. Endoscopy plays a significant role not only in the diagnosis as well as in prognosis too. A successful diagnosis helps for successful treatment. In this study, all the 20 patients shows some or the other endoscopic findings. Itself suggests the necessity of the endoscopy to identify the different possibilities of acid disorders which occur in the Parinamashoola. This endoscopic finding suggests that Parinamashoola is not a single disease entity to make all it as a syndrome. As these observations are comparatively small sample, it requires further more study to include the carcinoma of the stomach under the umbrella of Parinamashoola. Thank you one and all. And I am very much thankful to organizers of WAC for giving me an opportunity to come over here and present my talk. Thank you.